Colleagues, ladies and gentlemen, it's a great pleasure to welcome to this session on cardio-oncology and entitled An Evidence-Based and Multidisciplinary Approach to Cardiotoxicity in Cancer Therapy. The cardio-oncology is one of the most rapidly developing areas in cardiovascular medicine. And it's my pleasure. Today we have four moderators and four distinguished the speakers. And it's my pleasure to introduce our first speaker, Dr. Toros Sadigova from Azerbaijan. And I would like to introduce my co-speakers. They're co-moderators. The Professor Yang Sun from China, Koji Hagiwara from Japan, and Jinyu Chen from China. And I would like to give the floor to the Professor Sadigova from Azerbaijan. Please, Professor, floor is yours.
Okay. Good morning, everyone. It's 6:30 a.m. in Azerbaijan, in Baku, and I'm very happy to be here among such as distinguished speakers and these professionals in this field. So today I'm going to talk about mechanism and spectrum of cardiotoxicity in cancer therapy. Just a second, I'll try to move on. So let me begin with the question, why does cardiotoxicity matter so much right now? We're living through a revolution in cancer therapy, and more than 17 million cancer survivors are alive globally today in 2026. This is an extraordinary achievement in modern oncology. But here is a paradox. Cardiovascular disease has now become the leading non-cancer cause of death in cancer survivors. And as you can see, it's about 50% of non-cancer mortality. And just think about that. We saved patients from cancer, but we're paying with their hearts. More than 200 new anti-cancer agents were developed at the last decade alone, but more than 30% anti-tumor regimens have anthracyclines in like anti-tumor treatment. And the main point of cardio-oncology is that the integrated cardio-oncology care is no longer optional. It is a clinical and public health imperative. And European Society of Cardiology guidelines, which were established in 2022, pointed on that the cardio-oncology, it's a fast growing subspecialty in medicine, which every cardiologist who sees cancer patient must equip and must know how to manage with. So, to understand where we are right now, I want us to look back to the middle of last century, let's say, and in 1950s and 70s, anthracyclines, doxorubicin in particular, first alerted us to the possibility of chemotherapy-induced heart diseases. Then in 90s, different type of cardiotoxicity appeared, and it was a HER2 therapy caused, in particular, cardiotoxicity caused by trastuzumab. And the positive thing about this cardiotoxicity was that it is a reversible type of the cardiotoxicity. Then in the beginning of this century, tyrosine kinase inhibitors revealed this kind of side effect during the using of sunitinib and imatinib, like hypertension and ischemia. And at the same time, immune checkpoint inhibitors cause the cardiotoxicity like immune myocarditis, which is very rare but very fatal. And I think one of my colleagues today are going to talk about it also. And more recently, therapy with CART have brought cytokine storm associated cardiomyopathy. And today we are entering the era of precision cardio-oncology with AI risk prediction, multi-omics, and digital monitoring. So, in 2022, as I said, European Society of Cardiology made a great work establishing this framework for cardio-oncology. And what they did actually it was really great because they proved that they changed the definition. So the cancer therapy related cardiovascular toxicity was suggested, and it's not just a heart failure or cardiomyopathy. It is a big cluster of cardiovascular diseases from myocarditis to different types of the conduction disorders and to see how they spread the cardiotoxicity spectrum, I just prepared this slide. And as you can see, that the cardiomyopathy and heart failure are still leading cardiotoxic manifestations. And this is due to it's not a surprise, it's not a probably, it's actually, it's due to the, uh, most of the treatments and therapy. And it is that the arrhythmias, QT prolongations, like they also have uh, percentage. I want to also emphasize from patients, like from the start, from the scratch, oncology process, already due to the inflammation at these types of the patients, all of these patients is under the major risk of the thromboembolic complications due to the chemotherapy, due to the surgical involvements, and due to oncology itself. So let's go on. And to understand actually what's going on, we need to know a little bit about the pathophysiology of this damage. So before we dive into specific drug classes, I want to give a bigger scratch like this. And it begins with the cancer therapy exposure, triggering direct cellular injury to cardiomyocytes and endothelial cells. And initiates this whole cascade from oxidative stress and reactive oxygen species generation, which is particularly important for the use of the anthracyclines, which is followed also by mitochondrial dysfunction. And this will lead to inflammation and immune activation, which then drives to the myocardial fibrosis and remodeling. And after all of these processes, the major clinical manifestation of the cardiovascular diseases occurs. Along all this way, several parallel pathways accelerate the process, like the cardiomyocyte apoptosis, autophagy impairment, and T cells macrophage activation. And this last mechanism be crucial for ICI related toxicity. So let us now go a little bit deeper to anthracycline cardiotoxicity. And the mechanism is multifaceted. Anthracycline exposure causes topoisomerase 2 beta inhibition in cardiomyocytes, and this triggers reactive oxygen species and free radical generation. The iron doxorubicin complexes generate superoxide and hydroxyl radicals that are directly toxic to cardiac tissue. And this is really crucial because this inhibition triggers double strand DNA, which breaks cardiomyocytes and damage cardiomyocyte itself. and heart cannot repair adequately. The mitochondrial permeability transition pore opens, releasing cytochrome C and inhibiting the apoptotic cascade. That's why the cardiomyocytes are they getting disrupted with further reducing of the cardiac resilience. And the clinical fact is that toxicity, this type of the toxicity, is dose dependent and above the 400 milligrams per squared meter, it's combined with the higher risk of the uh, cardiotoxicity, the risk increases dramatically. And the risk is amplified also if the patient had a prior radiation or pre-existing cardiovascular diseases or some of the risk factors like hypertension or diabetes. And another risk, and the major risk, is that the most of the patients in oncology departments are 65 plus and they have lots of comorbidities. So the timeline is crucial in the anthracycline clinical spectrum. Acutely during the treatment for within the first days, patient might develop different changes on ACG like a QT prolongation, supraventricular arrhythmias, changes in ST segments or the T wave. Pericarditis are pretty rare in in the acute period, and we are lucky if we can catch the LV dysfunction during this period. The early onset happens a little bit after several months of the starting of the anthracycline therapy. And here at this moment, we can see the LV dysfunction with the heart failure with reduced ejection fraction. Sometimes like sudden cardiac death that can appear a decade or even 2 decades after the treatment. And this is pretty devastating that the most of the pediatric survivors might experience cardiovascular complications after even 2 decades after the prior anthracycline treatment. And we need to remember that the pediatric patients supposed to have the lifelong follow-ups if they had the anthracycline and therapy. So anthracycline cardiotoxicity, as I said, can manifest up to 20 years. Another type of the cardiotoxicity, it's a HER2 targeted therapy with the trastuzumab in particular. And the concept that fundamentally changed how we understood the cardiotoxicity. And it's completely differs from the type 1 anthracycline caused cardiotoxicity. So HR2 is not just a cancer driver, it is a critical survival signal for cardiomyocytes through the neurogulin PI3K-AKT-mTOR pathway. When trastuzumab blocks ERBB2 in the heart, it disrupts the survival pathway and causes LV dysfunction. And this is a major word, so dysfunction, not damage of the cardiomyocytes. That's why the type 2 cardiotoxicity is reversible. And when you just stop the therapy with the trastuzumab, the LV function restores, and the oncologist can go on with their anti-tumor therapy. Another type of the cardiotoxicity, it's a tyrosine kinase inhibitor caused by tyrosine kinase inhibitors. And it's a little bit different pattern of cardiotoxicity. As you can see, the LV dysfunction and heart failure occurs only at the 5-10%, at 5-15% at the patients who are using sunitinib and sorafenib. The major clinical manifestation is hypertension. It's like occurs at the 45% of the patient who are using TKIs. And Um, the QT prolongation also might be present at this size of the patient when they're using the TKI inhibitors like vandetanib and dasatinib. Ischemia and acute coronary syndrome occurring here because of the atherosclerosis acceleration, because TKI kinase inhibitors accelerating, they're acting on the endothelium function and they're accelerating atherosclerotic process. I will go through that ICI myocarditis, and as I said, I know that one of my colleagues are going to present about it also, but I want to stop on this slide. So we are now dealing, I will not talk about the pathogenesis. I hope my colleague is going to explain this, but I want to say that the myelitis is like overall, we have less than 1% of this incidence worldwide. But the mortality rate, looked at the numbers, it's about 30-50% in this patient has a high mortality rate due to the immune-related adverse events. And this mechanism doubles, this incidence like of myocarditis doubles when they have dual therapy with ICI inhibitors, like immune checkpoint inhibitors. It's like multiples 7 times. Excuse me. Like, for example, if the patient uses combined therapy with anti-PD-1 and anti-CTLA-4 inhibitors, the incidence is 17 times higher. And this is a medical emergency moment. The diagnosis requires high clinical suspicion, cardiac MRI, and often endomyocardial biopsy. Treatment are high-dose corticosteroids, and in refractory cases, advanced immunosuppression, and it's supposed to start immediately. Another side effects of cardiotoxicity, of cardiotoxicity caused by immune checkpoint inhibitors are arrhythmias, acute pericarditis, vasculitis, thromboembolism, accelerated coronary artery disease, acute coronary and Takayasu syndrome in some cases. Say cardiovascular diseases caused by anti-tumor therapy, it's a radiation-induced cardiovascular diseases. And the pathogenesis involved with endothelial is due to the endothelial injury from ionizing radiation, which triggers chronic inflammation and leads to fibrosis and accelerates the atherosclerosis. And this process evolves over the decade. Look at this timeline. In the first 6 months, the patient majority might experience acute pericarditis, arrhythmias, and myocarditis. And if this patient is not properly treated, in following 6 months up to 5 years, this patient might be presented with coronary artery disease, valvular disease, and pericardial effusion. Then the later on, constrictive pericarditis with the heart failure with reduced ejection fraction occurs. And later on, each manifestation is like going worse and worse and worse. But the good news are that the modern radiation planning is about the proton beam therapy, heart-sparing techniques, deep inspiration, breath hold, and substantially reduces cardiac exposure. But this patient must be followed for life. And also, I want to say that key quantitative risk data is that every 1 gray increase in mean cardiac dose and doubles the risk of coronary artery disease. This
Sorry,
translates to an absolute of 7.4% per decade.
sorry, Professor. In the interest of the time, may we ask you to conclude in a minute?
Yes, the second, okay. I hope that so biomarkers are also crucial. We need to start with the biomarker before starting the anti-tumor therapy. And like a baseline assessment is including echocardiography with GLS, and its GLS is important because it's the most sensitive metric tool, and increase in 15%. It's a marker of the early cardiotoxicity. I will not stop on the risk stratification that was suggested by Heart Failure Association, but it's also crucial because the pre-treatment baseline and risk stratification are leading us through the next steps, and we need to know this risk so we will manage our patient properly. Uh, I will help a little bit on the prevention that the dexrazoxane is only FDA and EMA approved cardioprotectant, and it reduces ROS generation. That's why it's supposed to use, but unfortunately it's not used in our country. And if your patient has some kind of cardiovascular complications due to the chemotherapy, you're supposed to manage them due to the guidelines for each manifestation. And management, I will go like I have also the global perspective and social, like different cardiac societies, cardio, the comparison, and the approach is pretty same in all of these societies, with the echo mandatory at the baseline and with the biomarkers mandatory at the baseline, but it's a little bit different during the treatment and the post-treatment tactics. And I want to say that the future of directions, it's a AI and precision cardio oncology, and now two hearts respond alike. Precision cardio oncology uses patients' genomic imaging and variable data to tailor cancer therapy to their individual cardio right dose for the right time. And this is a key for your attention. Sorry, I was a little bit long.
So, thank you. Thank you very much, Dr. Sadigova, for the excellent presentation. And you provided very important framework of this session that show that it is cardiotoxicity is a rather broad and heterogeneous group of the different complications. And now I will share my I will hand over to my colleague, Dr. Tong Lin, this chairing. And dear participants, please send your questions via chat. We will address these questions after the end of this session, by the end of this session. Please, Professor Tong Lin.
Okay, thank you very much. So let's move on. The second speaker in this session is Dr. Liu Ying from the First Affiliated Hospital of Dalian Medical University. She is also the leader of the cardiology department of the Dalian Medical University, and she do a lot of work regarding to the management of the patient with cardiologies. Also, she also a director of Department of Heart Failure in the First Affiliated Hospital at Dalian Medical University. She's the title of she's the lecture. Her lecture is please go to previous the multidisciplinary management of therapy-related cardiotoxicity and prevention strategies. Welcome, please, Dr. Liu. Thank you.
Thank you, Professor Liu Tong. Dear Professor, good morning. My name is Ying Liu from the First Affiliated Hospital of Dalian Medical University. It's my honor to be present our work on the talk of the multidisciplinary management therapy-related cardiotoxicity and prevention strategies. There are the growing burden of cardiotoxicity in cancer care. Cardiovascular disease has become one of the leading non-cancer causes of death among long-term cancer survivors, with approximately 10 to 30% of all deaths in selected cohort being occurred by it, with risk varied by cancer type and treatment exposure. As follow-up period increased, the impact of cardiovascular disease on cancer patient is becoming greater than that of the cancer itself. It is suggested that by this shift that a focus solely on cancer control is no longer sufficient. Cardiovascular safety is becoming a key determinant in the comprehensive management of cancer treatment. Cancer therapy-related cardiotoxicity is not a single uniform phenomenon, but a group of conditions with clearly different drug-specific risk patterns. In other words, different cancer treatments are associated with different types and levels of cardiovascular risk. For this reason, cardiovascular risk assessment should not remain at a broad treatment level. Instead, it needs to consider the actual conditions so that we can achieve more precise risk stratification and more personality patient management. A significant difference exists between cardiologists and oncologists in the management of cancer therapy-related cardiovascular toxicity, where cardiologists emphasize early detection and prevention. Oncologists prioritize the continually of anti-cancer therapy. This divergent perspective lead to inconsistent decision relating early screening and symptomics. Invention ultimately contributed to the opposite of standard clinical pathway. In such a complex field, this interspecialty gap remains a key barrier to automatic patient care. Because oncology and cardiology are often different in how they understand and management toxicity. The field of cardio-oncology has rapidly developed a series of evidence-based guidelines and expert consensus statements. These documents provide a structured framework for risk assessment, monitoring, and intervention across the entire cancer treatment pathway. However, despite this advanced real-world implementation is still limited, and standard in clinical practice remain a key challenge. Among all current documented, the 2022 U.S. cardio-oncology guidelines are widely regarded as a cornerstone of the field. They not only define cancer treatment-related cardiovascular toxicity in the standard way, but also provide a comprehensive framework. Most existing clinical study in cardio-oncology are designed to validate the findings present in the 2022 U.S. guidelines. Conduct further more detailed investigations or address gaps identified in the guideline. The risk stratification and early detection evidence-based framework. The 2022 U.S. guideline on cardio-oncology promotes a systematic pathway for cardiotoxicity monitoring, emphasizes cardiovascular management across the entire course of the cancer treatment rather than intervention only after heart failure symptoms appeared. Before anti-cancer treatment, all patients should undergo baseline cardiovascular risk assessment. According to this assessment, patients are stratified into low, moderate, and high-risk group. For low-risk patients, the main strategy is lifestyle management and regular assessment. For moderate risk patients, prophylactic cardioprospective therapy may be considered when necessary. Together with post-treatment cardio function follow-up for high-risk patients, more accurate prevention and closer surveillance were required, including early assessment after treatment, regular echocardiographer, and annual cardiovascular risk evaluation. Based on the monitoring pathway promoted by the ES guidelines, a recent study has further highlighted the value of integrating dynamic biomarkers and advanced imaging parameters into cardiovascular surveillance for cancer patients. This is particularly important because different anti-cancer therapy may cause the different pattern of cardiovascular injury, therefore require a therapy-specific monitoring strategy. Beyond conventional LVEF monitoring, recent study has focused on the value of novel echocardiographic parameters for early detection of the cancer therapy-related cardio dysfunction. GRS is now one of the most widely used indicator of subclinical myocardial injury. As mentioned above, cardiovascular risk assessment is the first step in the monitoring pathway. This raises an important question. Is there a recognized tool in cardiology that helps us assess cardiovascular risk before cancer therapy? One widely used frequent is the half-echoes risk assessment scale. The score is integrated patient-related factors such as pre-existing cardiovascular disease and traditional risk factors together with the cancer therapy-related factors. Baseline biomarkers and cardio imaging finding based on these variable patients can be classified into different risk categories, which help clinicians decide who require close monitoring, early cardioprotective therapy, or long-term follow-up. However, this is important to recognize that the current risk stratification tool may still fall short of the expectation. In recent years, the number of the prediction models used in cardiology has increased rapidly. By 2024, a total of 63 prediction models have been reported in the field. Decrease this growth, this clinical performance remains suboptimal. Many studies has reported that most CTR-CD prediction model carry a high risk base. Clinically, these patients may actually require a high level of surveillance, yet they are classified as low or moderate risk. This highlights an urgent need to further validate and optimize risk model according to different anti-cancer therapy and the real-world patients population. Prevention and management of cardiotoxicity, evidence-based practice. After cardiovascular risk assessment and stratification, the next key question is how to translate risk identification into effective prevention. Prevention in cardio-oncology should be understood as a continuously process across the one cancer treatment pathway. For patients at higher cardiovascular risk, pharmacological cardioprotection may be considered, including ACI, beta blocker, agonist, SGLT2 inhibitor, and other heart failure-related therapies. According to clinical context, at the same time, non-pharmacological approach, especially exercise-based intervention, also play an important role by improve cardiorespiratory fitness and preserving cardiovascular reserve. In terms of the pharmacological prevention, drugs originally used for heart failure treatment have first attracted increasing attention in cardiology. Among them, earlier has been explored as a potential cardioprotective strategy against therapeutically induced cardiotoxicity. The SAFE trial provide important evidence for pharmacological cardioprotection in anthracycline treated breast cancer patients. So this randomized placebo-controlled double-blind study evaluated the bisoprolol and their combination for the prevention of the subclinical cardio injury. So this is protected the cardiotoxicity. SGLT2 inhibitor have recently emerged as a potential therapeutic option in cardio-oncology. In this study, patients with type 2 diabetes and CTLA who received the SGLT2 inhibitor in addition to contemporary guide-directed medical therapy had fewer heart failure, extraction, and low all-cause mortality during 2 years of follow-up. SGLT2 inhibitor use is also associated with the fewer hospitalization or emergency department visit, as well as low risk of atrial fibrillation of lateral, acute kidney injury, and renal replacement therapy. So exercise is the important method of protection in cardio-oncology. Multidisciplinary decision maker in cardio-oncology care. Cardio-oncology is inherently a multidisciplinary and collaborative specialty. This goal is not only to treat cardiovascular complications, but to provide the coordinate cardiovascular care throughout the entire cancer journey, so that patients can safely and complete effective cancer therapy. The work of cardio-oncology team can be divided into 3 stages. Before cancer treatment, the team focuses on the comprehensive cardiovascular risk stratification and optimization of the modifiable risk factors. During treatment, the priority is early detection of CTLA throughout biomarker and advanced imaging, followed by tablet intervention to avoid unnecessary interruption of cancer therapy. After treatment, a long-term follow-up is necessary to screen for late cardiovascular toxicity and continuously reassess emerging cardiovascular risk. While building a cardio-oncology service, it should be seen simply as a joint outpatient clinic, but as a structured care system covering the entire cancer treatment pathway. A mature service usually includes 3 key components. First, a multidisciplinary team includes cardio-oncology, oncology, hematology, radiation oncology, imaging specialists, a nurse, and a pharmacist, working together on risk assessment, toxicity detection, and treatment decision. Secondly, a standard clinical pathway. Patients should receive baseline cardiovascular assessment before treatment, during therapy, Monitoring should be adjusted according to the risk level, and at the site of cardiotoxicity should trigger rapid referred or MDT discussion. Third, a long-term follow-up system focuses not only on acute cardiotoxicity during treatment, but also on the late cardiovascular complication in cancer survivors. In practice, oncology service can take different forms, such as joint clinic, fast-track consultation, inpatient MDT meeting, tele follow-up, or multi-hospitalized networks. The actual model may vary, but the core remained the same. Clear referral criteria, uniform monitoring protocols, rapid diagnosis, access, and the shared discussion making between oncology and cardiology. So we also need multidisciplinary free-willed collaboration. In order to promote the close collaboration between the field of oncology and cardiology, efforts to raise the awareness of the oncology has been intensified, and up to now, more and more cardiology clinical centers are set up. And up to now, more and more cardiology clinical centers are set up in China. More than 30 cardiology societies have established. We are devoting to improve outcome of the patients in China. Support of organizations like the CARCASS and Cisco, we promote research and foster collaboration across the country. We established a cardiology MDT meeting weekly to share knowledge, conduct care discussion, and educate each other. We develop a provision and monitoring system of cardiology. Additional national guideline and consensus document on cardiology has been published to guide clinical practice and improve outcome for cancer patients. This year, we launched a new English language journal, the Journal of Cardiology, under the Chinese Medicine Association. We invited submissions worldwide for it in audio issue. Currently, we are conducting 6 multi-center clinical trials. So in summary, we are committing to advancing cardiology through research collaborations and innovation. Together, we strive to improve patients' outcome. Thank you very much.
So thank you very much, Professor Ying Liu's lectures. And so Professor Liu introduced a very important concept is multidisciplinary strategies therapy in the field of cardiology. Also introduced the development of the cardio-oncology in China. We developed more than 30 societies in cardiology. Also, we have a lot of the guideline and regarding to the cardiology. I think in China in the future we are together with all the member of the other countries in all these sessions, and we together to improve the quality of the patient. Thank you very much. So for the time being, I move to the moderator to the Professor Qun Shao from Harbin Medical University. Please, Professor Shao.
Okay, so the next speaker is Dr. Fozolov. His topic is acute coronary syndromes and cancer, diagnostic challenge and treatment options. Please. Dr. Fozolov, we can't hear you.
Are you hear me?
Okay.
Yeah. Okay, no problems with my report presentations? Okay, first of all, dear colleagues, let me express my sincere gratitude to our committee of SHE Research Summit for the opportunity to report our little experience about acute coronary syndromes in patients with cancers, diagnostic challenges, and treatment options. If you know, of course, cardiovascular disease and oncology disease is global and serious problems for healthcare system for every country. Approximately per year, 20 million patients died from cardiovascular disease, and approximately 10 million died from the oncology disease. And 70% patients with acute coronary syndrome have a current or prior cancer. More than 2 times the risk of arterial thrombotic events versus the general populations. And heart disease is now the leading cause of death among cancer survivors. As you see, cancer and cardiovascular disease increasingly converge in the same patients with acute coronary syndromes. And new guidelines for treatment patients with acute coronary syndromes, assessment need for new guidelines. It's necessary assessment, diagnosis, and treatment principles are shared. The key difference is the timing of invasive angiography. As you know, we have 3 forms of 2 forms of acute coronary syndrome: STEMI, non-STEMI. But for diagnostic method and treatment strategy, necessary assessment of risk, development, adverse outcomes. Of course, STEMI we need PCI. And why cancer patients develop coronary events? So we have 4 groups of reasons. First, of course, shared risk factors. It's age, smoking, diabetes, hypertension, obesity, hemodynamics, and hypercoagulable state, tumor-derived tissue factor, and inflammatory cytokines promote platelet activation and thrombosis. Third, treatment-related toxicity. Fluoropyrimidines, platinum agents, VEC, and tyrosine kinase inhibitors cause vasospasm and endothelial injury. And fourth, endothelial damage and accelerated atherosclerosis, classically involving the ostium and left main. And active cancer within the past 12 months is a major criterion for high bleeding risk at PCI. Yet overcaution must not become under treatment of the coronary event. Of course, patients with cancer and acute coronary syndrome, we must assessment ischemic thrombotic risk, bleeding risk. Of course, this patient has high bleeding risk because they have thrombocytopenia and anemia. Maybe they have tumor or mucosal bleeding, concomitant anticoagulation for atrial fibrillation or ventricle venous thromboembolization, renal hepatic dysfunction. Of course, these patients have high risk thrombotic and ischemic events because they have high burden and complex of coronary disease and hypercoagulable proteomic state and others. And this slide, you see, it's very important for patients with acute coronary syndrome and cancer. We must assessment ischemic thrombotic risk and bleeding risk. If the patient has very high ischemic thrombotic risk, we must choose invasive PCI. If the patient have low ischemic risk and high bleeding, in more cases, we must choose medical therapy. The diagnosis of cancer alone should never dictate therapy. Strategy is set by the balance of ischemic and bleeding risk together with life expectancy. Guiding device choice, antiplatelet intensity, and adapt duration on individual basis. And this slide we present algorithm turns acute coronary syndrome management in cancer patients into 2-step decisions. First, triage by ischemic urgency, then weighs life expectancy and bleeding risk. Invasive PCI with drug-eluting stents is favored when ischemic risk is high, while a tailored shortened dual antiplatelet therapy regimes and cardio-oncology follow-up applied throughout. If the patient has stable, non-STEMI, and low risk stable, we may choose conservative treatment, optical medical treatment. And if the patient has very high risk, bleeding risk, so we must choose medical treatment. And in this presentation, we present a clinical case, a patient, 65-year-old woman with active oral carcinoma and sanguineous three-vessel coronary disease, presenting as acute coronary syndrome, unstable angina. She have left ventricular ejection approximately 60%. When we assessment by TIMI score for unstable patients, she has 5 points. It means 26% risk at 40 days of mortality, myocardial infarction, and urgent hospitalizations. Patient has concomitant disease such as diabetes type 2 and arterial hypertension, chronic heart failure. So this you see, this is basilar coronary artery. You see critical stenosis of LID, approximately 45, 90% in the middle part of LID. And you see in circumflex artery mid segment have subtotal stenosis and diffuse atherosclerotic process in right coronary artery with stenosis approximately 85%. And of course, we organize a heart team consilium, and in this heart team, we include such specialists as intervention cardiologist, cardiac surgeon, cardiac oncologist, oncologist, hematologist, anesthesiologist. And for this case, of course, it was difficult to choose correctly revascularization method, but after consilium, we have recommended to patient KFG, but patient refused from KFG, so we decide perform PCI step by step. At first stage, we perform PCI LID. We put stent. You see this final results, good final results. And we put drug-eluting stents, 2.75 and long 33 millimeters. And in this stage, we perform PCI circumflex artery and put one drug-eluting stent with good observed results. And after the first stage, the patient take chemotherapy, and after cancer therapy, hemoglobin fell 129 till 107 gram/liters, and we wait a little for treatment anemia, and then we perform stage 2 PCI, and for in the second stage we perform PCI right coronary artery. We put 3 stents because the patient has diffuse coronary artery disease from the distal part till proximal part, 3 stents, drug-eluting stents. And after PCI, we recommend patient dual antiplatelet therapy, aspirin 75 milligrams and clopidogrel 75 milligrams, with high intensity statin, beta blockers, SGLT2 inhibitors, and mineral corticoids receptor antagonists. So, of course, for these patients, better choose clopidogrel over the ticagrelor and prasugrel because this ticagrelor and prasugrel has very high bleeding risk, and of course, keep short duration of dual antiplatelet therapy for these patients. And for us, and very important prognosis of the patients after the PCI. And we find this meta-analysis where it includes 20 studies and more than 9,000 record screening, and endpoints assessed in hospital mortality, long-term mortality, more than 1 year, major bleeding, myocardial infarction, stroke, and acute kidney injury. For in-hospital mortality, in this, you see in hospital deaths, cancer was risk ratio was 2.56, and for these patients, statistical significance, the risk of in-hospital mortality was very high in patients with cancer. But among patients who with treatment PCI, this statistical significance was lost, and risk ratio was 1.45. And so you see, if the patient is not treated by PCI, the excess risk was very high. Risk ratio was 4.02. Excuse me. And about long-term mortality, as you see, 12 studies and more than 600,000 patients included in this trials, 45,000 patients with cancer. And in this meta-analysis shows that the risk ratio was 3.55. The statistical significant difference, so the wide interval reflects substantial between study heterogeneity. And mortality reflects both cardiac and competitive oncology cause of death. And bleeding risk is meaningfully higher in this patient with cancer. Of course, crucial PCI raised bleeding risk no more than conservative management. Excess bleeding was similar whether or not PCI was performed. So, in patient with acute cancer syndrome, we can perform acute PCI and its bleeding risk similar as when we perform conservative treatment. Recurrent infarction after PCI is not increased. 12 studies were pulled for recurrent myocardial infarction in acute cancer syndrome, patient with versus without active cancer. The summary risk ratio was 1.01. The interval across 1 indicate no statistically significant difference between groups. And stroke and acute kidney injury, no significant accents, and so the group was similar for endpoint for acute kidney injury and significant excess. And for kidney injury and stroke, sorry. And what the evidence tells us? First, active cancer raises both in hospital and long-term mortality after acute coronary symptoms. Second, bleeding risk is meaningfully increased, the principal safety trade-off. Third, no access in the recurrent infarction, stroke, or acute kidney injury. Fourth, PCI mitigates early and some late mortality and does not add bleeding versus conservative treatment. Thank you very much, dear colleagues.
Okay, thank you. Thank you, Dr. Flozov, for the great talk. Based on our clinical observations, ACS syndromes in cancer patients are often atypical. So they are easily missed, especially in cancer centers. Many cardio-oncologists worry about bleeding risk, and they are not sure about the patient's life expectancy, which lead to the low proportion of patients receiving standard drug therapy and timely PCI. Some cancer patients might undergo surgical tumor removal in the coming month. So next generation DES may be better option since they can shorten depth duration. Thank you. And let me introduce the next moderator is Dr. Haixia Liu. Haixia Liu she's from another cancer hospital. She's also worked in Department of Cardiovascular Medicine. Welcome, Dr. Haixia Liu.
Thank you. Thank Dr. Shaoqun for the introducing. Then I would like to introduce the next speaker, Dr. Yu Hui Zhang. She is from Fuwai Hospital. She holds many academic my sound is hoarse. Like CMDA, CSA, CARCAR, and the others. She had many contributions to Chinese cardio-oncology. The title of her report is Early recognition and stratified management of immune checkpoint inhibitor associated myocarditis. Welcome, please.
Thank
Dr.
you. Thank you for introduction of Professor Liu, because I'm so sorry I'm in the airport, so I just make the pre-record of my speech. So please play it and I will join the discussion later. Thank you. It's my great pleasure to give the presentation on the early recognition and management of SCI myocarditis. I'm Yuhui Zhang. This is the main content of my presentation. The first is on the epidemiology of SCI myocarditis. The SCI myocarditis is the most studied and highest fertility and among the cardiovascular toxicity that caused by SCI. The myocarditis is the most important, and it can deteriorate within days from mild symptoms to cardiogenetic shocks and malignant arrhythmias, and it frequently overlapped with myositis and myasthenia. That is also called the triple M. The percentage of myocarditis caused by SCI is usually from the 0.04 to 1.1% overall incidence and up to 4% in real-world data. And the overall mortality for fulminant myocarditis is nearly 25 to 50%. And the combination therapy roughly doubles the incidence and carries higher mortality. The SCI-associated myocarditis also with or without myopathy. In patients with both had higher troponin T and CK level, and patients with isolated myocarditis have higher NT-proBNP and lower EF fraction and higher likelihood of acute composite heart failure. The overall SCI myocarditis incidence was 1.1 with a median onset of 44 days. And the SCI myocarditis markedly increased the risk of cardiac death and MACE and heart failure. And the triple M symptoms occurred in 20% at birth, associated with increased all-cause mortality. There is some data from the nationwide Chinese NSCLC cohort study, which include 55,000 patients, that shows the cumulative incidence was 4.8 was 0.0 per 1,000 person years, and supporting the enhanced myocarditis monitoring and early recognition in SCI-treated patients. Another study came from the nationwide French study, which includes 172,000 SCI-treated adult patients, and the SCI muscular toxicity occurs in 0.7 to 0.9 at 6 months, and the SCI myocarditis and myositis occurs in 0.3 to 0.6%, and the major factors for SCI muscular toxicity include the thymic tumor and also other skin cancers. And the triple M syndrome refers the triad of SCI-induced myasthenia and myositis and myocarditis, and the in-hospital mortality rate is as high as 38 to 43%. And the risk factors for developing myocarditis, which includes the dual SCI combination and the pre-existing CVD, diabetes, and advanced age, and the markers of poor prognosis, including the complete heart block or markedly elevated troponin T or troponin I on the prolonged PRQS interval and widened QRS, and also reduced LVEF and cardiogenic shock or malignant arrhythmia, and also the early onset and also the occurrence of triple M. The mechanism of SI cardiotoxicity, which includes the checkpoint blockade and antigen cross recognition, and also the CD8 T cell infiltration and the inflammatory amplification, such as the JAK STAT regulation, upregulation, and cytokine storm, and macrophage recruitment. The histopathologic also includes the lymphocytic myocarditis and the PD-L1 upregulation, and the macrophage enrichment high, and the study also shows the CXCR6 T cells, also a key marker of activity, which is a key marker of activated cardiac T cells. And the SCM myocarditis is driven by expansion of CXCR6 T cells, and identifying that is a potential target for the treatment. How to make the early recognition and diagnosis of SCM myocarditis? For the clinical spectrum, include the subclinical to cardiogenic shock, and the cardiac symptoms also include the chest pain, tightness, dyspnea, and palpitation, syncope, fatigue, and also have the muscle symptoms and the neural symptoms, and also the critical factors, including the hypotension, VT-NBF, and high-grade AV block. And the diagnostic workflow from the 2022 ESC cardio-oncology guideline, that there is a 5-step to suspect, act now, and confirm, and rule out, and stratify, and also the treatment. The 3 pillars, such as the hold SCI or the rapid diagnosis, and if unstable, to give high-dose steroid first. From the ACC clinical guideline for the SCI-associated myocarditis, that shows the epidemiology is about 0.04 to 1.15%, and only 20 to 50 are fatal or severe. And the diagnosis strategy, including the main diagnosis methods, to use the troponin and MRA or biopsy, and early screening in the first 12 weeks after SCI to check the CPK and AST/ALT and LDG every 2 weeks. If elevated, trigger troponin, and of those with more than 3 non-cardiac biomarker elevated, 95% can be diagnosed with myocarditis. For the troponin to screening and diagnosis of SCI myocarditis, there is some problems to which troponin for prognosis in SCI myocarditis, both troponin T or troponin I related the MACE risk, and troponin T can rise also from the skeletal muscle injury, and the troponin T and troponin I elevation may provide complementary information. In acute symptoms, troponin T is less specific for SCI myocarditis, and precisely definition and standardizing the MACE is essential for assessing and comparing diagnostic and prognostic activity. But the prospective study in large SI-treated cohort are still needed to clarify the clinical value of troponin TLI screening and their prediction of MACE and the overall outcome. The ECG is simple and cheap. The complete heart block also have the signal to strong mortality and the strongly time link to the early death. And for the echo, that substantial proportion serve EF, such as more than 50%, but normal LVEF does not exclude myocarditis. The LTS is more sensitive to early subclinical myocarditis involvement, and the impaired LTS correlated with adverse CV event and can detect abnormality while EF is still normal. The MRA that we usually use the T2 for edema, T1 or T1 mapping and LEG, LGE and elevated ECV, but the CMA is done within 4 days of admission. Up to nearly 70% can appear normal. So the negative CMA does not exclude the diagnosis, and the steroid should not be delayed waiting for it. The biopsy also have some limitation. That is, it is not often focal. So classic Dallas criteria have low sensitivity, and it also invasive, also have some complication risk, and do not delay high dose steroid while waiting for biopsy. And for the biopsy, to add CD68 immunohistochemistry to qualify the macrophage and raise the sensitivity. And the severity grading, there is a 3-complementary system. The CTCAE V5 myocarditis grading, and also the ECG fulminant versus non-fulminant, and also other risk score. For the management of SI myocarditis, there is 3 pillars of treatment according to the ESC guideline. The first is stop SI immediately for suspected cases, and the 2 rapid diagnosis according to the biomarker ECG or CMRA, and to explode ACS and other viral myocarditis, and the early high dose of steroid if necessary. And the throughout stage, it is very important to set up the MDD, including the cardiology and oncology, and also critical care and neurology and pathology to set up the GDMT group. And the first line of corticosteroid treatment, the dosage and the timing and ASCO variant and response is the key point of use of steroid. And the earlier start can cause the better MACE-free survival. Both higher dose and earlier start associated with better cardiac outcomes. For the steroid taper or second-line immunosuppression, for the tapping principles, including usually tap off over weeks for 4 to 6 weeks, and keep monitoring troponin, ECG, and cardiac function, if rebound or reverse, to slow the taper or re-escalate therapy. For second line, usually for the steroid-resistant or fulminant myocarditis, which include the MMF or ATG or FAV, and also the plasma exchange. For the emerging target, which include the abatacept and also the JAK inhibitor, there is a small sample study that shows the combination of abatacept and JAK inhibitors can reduce the mortality from 6% to 3% in a small cohort study. And for the critical care, if the patients have the high grade or complete block, to consider the timely contemporary pacing. And for the unstable patients, for the fulminant disease, often need to pump treatment such as the IBP or ECMO if needed. For the triple M overlap, to avoid the respiratory shock, and also to consider keep the incubation ready, and also the earlier plasma exchange, and also avoid drugs that worsening the misthenia. That is the suggestion came from the 2025 ACC clinical guideline, and also the core treatment principles, such as stop ICI immediately for grade 2 toxicity and earlier high dose steroid therapy. And if steroid response failure, such as the troponin not fail or clinical worsening, to add the abatacept or JAK inhibitor. For the ICI re-challenging, for severe myocarditis usually means permanent ICI discontinuation. For mild cases or symptomatic biomarker rise, when no alternative exists, reducing may be done under closing monitoring to avoid combination therapy. For the long-term follow-up and future direction, for long-term risk, ICI can accelerate atherosclerosis, increasing MI and stroke rise. Traditional ASCVD risk tools may underestimate the risk, and studying can use to slow the plaque progression and improve overall survival. For future directions, the machine learning models to predict individual toxicity risk, and studying such as the SGLT2 inhibitor or GLP-1 receptor agonist in cancer therapy related cardiac dysfunction. It needs randomized trial of novel immunomodulators. And that is a case from our heart failure center of ICI-associated myocarditis. It is male patients with 1 year anti-therapy, and it is found to have the ECG abnormal and elevated cardiac enzyme for 1 month ICS treatment, and the patients have symptoms of fatigue and abnormal ECG, such as the V to V2, V3, R, and VR at ST elevated, and also the troponin I persistently elevated, and also the echo shows the normal EF, and the MRA shows the partly edema, and the we give the biopsy that shows in the electron microscopy shows the severe myocardial injury and favoring inflammatory myocardial injury. And we just stop the SES therapy and to give the steroid therapy and all the symptoms and the CMI improved after the treatment. And in the late stage, we just to cooperate with the oncology doctor to restart the SCI treatment with a very low dosage, and also to give the monitoring troponin I and echo, and to avoid the new occurrence of SCI-associated myocarditis. Thank you so much.
Thank you. Thank you, wonderful report and good jobs. ICS myocarditis is a challenge in cancer treatment. Early identification and treatment is important. I am from a cancer hospital, ICS myocarditis, we have many patients. Thankful, Yu Hui Zhang, Dr. Yu Hui Zhang. Thanks. Now, the next session time, overtime, or discussing part. Continue discussing part.
Yes, thank you. Thank you, Professor, for chairing, and thank you very great discussions. Very great presentations. Our speakers. We had a very comprehensive overview of modern cardio-oncology today, and from mechanisms, from myocarditis, from acute coronary syndromes, and prevention strategies. Now, I think we would now to open the floor for discussion, and it seems we have no questions in chat. No, maybe any questions from our co-chairs, from my colleagues to the our speakers. Professor Tong, do you have any question to our speakers or my colleagues, Hexia Liu or Professor? If you have any question, because you have you mentioned that you have you work at the oncology clinic and you have many patients. You see many patients with these complications of chemotherapy. I think it was very interesting lecture presentation from all presentations. They were great, but for me it was interesting to listen the experience from Professor Fazilov, because acute coronary syndrome in patients with in cancer therapy, in the patients with the cancer patients, is really very challenging. And one question to Professor Fazilov, and in your own practice, Professor, how often you see these patients with acute coronary syndrome, and if these patients are on the chemotherapy or the after chemotherapy, and the age of this patient? Of course, I think maybe these patients are mostly 60 plus. I don't know, but I'm asking about this. And if they had a history of cardiovascular disease, or some of these patients, they don't have any symptoms of cardiovascular disease. Maybe it was the hidden, and they weren't recognized. Please. Professor, we don't hear you. Professor Fazilov, we don't hear you.
Thank you very much for your questions. In our clinic, not frequently come patients with acute coronary syndrome and cancer, but per year, approximately 5 or 6 patients will get with coronary artery disease and oncology disease with cancer. In Tashkent, we have approximately 15 clinics where a patient get interventional treatment for coronary artery disease. Maybe other patients go to others clinic. So when this patient come to our clinic with acute coronary syndrome, comes without chemotherapy, they come before chemotherapy because a lot of case oncology send us these patients for first stage treatment coronary artery problems, then they get chemotherapy. And after chemotherapy comes with cardiotoxicity, and when the patient development myocarditis or cardiomyopathy with reduced left ventricle ejection fraction. We have a lot of such patients after chemotherapy. But when it comes with acute cancer, this patient a lot of before chemotherapy.
Thank you so much. Thank you very much. And colleagues, any questions? No questions. Okay. About the therapy, this cancer therapy and myocarditis, Professor Ian Liu, and how approximately in your clinic, how many times or what is the incidence of the cardiotoxicity or myocarditis in your clinic? Because Professor Fazilov, he mentioned that they see these patients very often, and how many and which treatment, which kind of chemotherapy mostly lead to the myocarditis, or it doesn't matter.
Thank you.
Practical doctors, for the practical doctor or the cardio-oncologist, he should know that this treatment and this age group, okay, we have the scale in order to, we have the special the scores to recognize these patients in order to recognize this patient who is prone to this cardiotoxicity, yes? But how often you see them and if it is preventable in practice, okay?
Okay, thank you very much. Because we have about the 5 department of oncology, so there is many patients in oncology department. So there almost every day, there are many patients need to help of cardiology. So we also do consultation with those patients, such as basic risk, high risk dysfunction, high risk stratification is high risk. So we recommend that those patients have the RNA and the HLT2 to protect prevention of the heart failure. So I think we also close the consultation with the doctor of the oncology. Thank you very much.
Thank you so much for your comprehensive lecture and your answer. Thank you. And dear colleagues, if you don't mind, we will close our session if there are no questions and no discussions yet.
Okay. Thank you very much. Thank you.
Thank you very much.
Thank you.
Bye-bye.
Thank you so much,
See you.
dear colleagues.
See you in Great Tour Congress in Beijing.
Yeah.
October.
Hope to see you in Peking.
See you.
Peking.
See you
Bye-bye.
again in October, Beijing. Bye-bye.
See you.
October.
Bye-bye.